coming to the point, I will be talking on static versus dynamic spacers. So joint is under attack. PGI is a devastating complications which we all know. And obviously there is no gold standard for diagnosis. There has been so many recommendations what the diagnosis algorithm should be from the European Committee, from the US, and what we follow. And there is an enigma, what do we do? Do we do in one stage or two stage? To be very fair and frank and talking in front of you all guys, what I would say in India, the gold standard would be a two-stage revision. We have had a good talk with Dr. Gogoi, who talked about Dyer and similar other protocols for the one single stage. And since I've been an endocrinic fellow, I did practice in the very beginning, but now it's just two stage what we do. So basically one stage revision is removal of the prosthesis and just remove aggressive tissue debridement and take it from there. But when we talk of two-stage revision, we need to put something inside and we do a proper debridement. So as Dr. Manuj Wadhwa has shown a very well video that we need to take out the prosthesis well and then we need to put something inside. Now there comes two bifurcations, whether we put something known as static spacers or dynamic spacers. Static spacers are very easy. Basically, it is any spacer is a biocompatible device inserted into a joint to maintain the joint spacer, deliver antibiotics locally and to stabilize the joint and prevent bone tissue collapse and facilitate future revision surgeries. So as I was telling, dynamic and static. So when you talk of static spacers, they are very easy to put. You just have to mix antibiotic, create a mold and take it from there. It was first described by Cohen, historically performed. Still it is performed, easy to go. And it's very simple. Just plan it on table and take it from there. Problems in all these are that you don't actually know about the antibiotic, how much antibiotic has to be put in. So these things are to be taken into consideration. But when we talk of static spacers, it restricts knee movements, distracts and preserves the joint space. It does provide stability to the limb, but it does provide contracture to the extensor or abductors mechanism, and it might cause arthroplasty and it is painful. So then came the concept of dynamic spacers. Articulating or dynamic spacers are basically prepared on table, or I just saw one stall outside, you can have ready-made spacers, dynamic spacers. So one is molded, which you make it on the table, and the other is preformed. So these are the ones we make it on the table. Problem with these spacers are that, frankly speaking, you need two teams, one patient team, one surgeon team, preparing the spacer on the table, and the other surgeon taking out the implant, because if you add on these two, the time goes high and it takes time. Second problem, practical problem, usually the molds are bigger in size, which I will show you, and generally in Indian population the lower sizes of the femur are available, 1, 2, 3, and these molds are bigger. So both problems, both in these ready-made and the available ones, these are the problems, and making time is at least half an hour. So we prepare something like this and take it from there. This is the pre-formed, but the size mismatch is always there in most of the patients. So we have to take care that we take the smaller size, or once you have because most of the patients don't have the implant details with them and we just judge it. And these are some examples of dynamic spacer put in the hips. We also have one, this is just taken from the internet, Prostalac, which is dynamic spacer. And basically, what are the advantages? Of course, patient can mobilize, knee ROM is possible, but you have dislocations. You get patients like this, because patients also become so much aggressive and they keep it for longer time than what we expect. So these are some complications of dynamic spacers. These are the complications in which the spacers put are too large, so you can't close the skin. So ultimately you end up in vacuum dressing and flap reconstructions. So, but when you talk of static spacers, the knee is in extension, or hip is in hip also it dislocates. So second most important thing is that what are the important types of cement which you can put. So basically it should be stable, non-toxic, water soluble and minimize antibiotic resistance. So avoid liquid antibiotics. Vancomycin is good, but generally people take one vial of vancomycin, 500 milligrams, and take it from there. But ideally 1500 should be put. So we have to understand the cement, and preferably what I prefer is to use pre-mixed cement with antibiotics. So Palapocos is the most effective antibiotic, effective delivery device, then Simplex, and we have so many varieties which we use, and it's important because it is pre-mixed with the proper concentration. And these are some of the antibiotics which are generally used. So the recommended doses of antibiotics are 2.2 to 5 times higher for therapeutic use than that we put. And of course, when we put these spacers, what is the ideal time when you revise it? This is a huge debate. 6 weeks, 6 months, 3 months, we all don't know. Serial CRPs and weekly monitoring of CBC, ASR, CRP is essential. So in conclusion, what I would like to say, at the end of the day, I would like to say that Indian scenario, go for 2-stage revision. Dynamic spacers are good, but complications are higher. If you make it on table, the time is a bit more, like minimum half an hour to prepare the whole mold, and it is a good effective solution. You can make the patient understand. These are some handmade spacers which we made it at our place using some Steinman pin, but now we do all dynamic spacers, and we did an ETO. Some examples, we in our place we get static spacers put in which had dislocation. Patients come something like this, and then you have to revise all these things. So both the things has got simultaneous complications, and this is one of my paper published in the Journal of Bone and Joint, in which we studied 110 patients with revisions. About 35% of the patients were having septic revision, and out of all those 35, we did 2-stage with dynamic spacers. So this is published in JBJS. So there are so many guides, especially one of these available in the endo clinic, and you should read, understand, try to be at the stalls, understand what antibiotics, because the one of the companies which is providing is just providing only gentamicin, that is performed knee spacer. So that is of no use if you want vancomycin or rifampicin to be added. Then you have to mold it on table. So with this, I would like to thank Ms. Dr. Ramneek Mahajan sir for having me here, and these are some references. Thank you.